That'll be fun for you,
I don't
though.
have to travel, but yeah, just doing R&Ds, I can do that from home and then send it
It's a warm place, though.
So Sarasota is a warm place, but it's muggy and goo.
Yeah, Florida.
It's Gulf Coast, and it's
a whole bunch of Floridians there, too. It's not great.
Which
you are, just,
do you like PT Cruisers?
Do you like old people? Okay. So, I think we finished female reproductive system, didn't we?
Yeah.
Okay. You guys are way ahead of the other class, so we'll do a male reproductive system. Where's your... No? Okay. You guys are a match set, so, okay. So we're going to start with the male reproductive system anatomy. And we will start with, not that, wrong one. We will start with scrotum, yeah? And as we're going through this, let's just remind ourselves of the homologous structures that we've already covered. So when you were talking about the scrotum, what is the female homologous structure to the male scrotum? Labia majora, exactly. So the scrotum is here. The scrotum is a combination of skin, connective tissue, and muscle. Its primary job is to protect the testes and also to do thermoregulation of the testes because of the musculature in the wall. So, of course, after puberty, the scrotum is generally going to have pubic hair on it, like the labia majora does. And then there's a couple of different layers of muscle associated with it. The first muscle is the smooth muscle that's just deep to the skin of the scrotum, and that's called the dartos muscle. All that really does is sort of wrinkle the skin and tighten the skin of the scrotum. It doesn't really raise and elevate tremendously. And then deep to that, you are going to start to run into this tissue, and this tissue is called the cremaster muscle. That's skeletal muscle. It's actually a continuation with the internal oblique muscles. Its job is primarily raising and lowering the testes because spermatogenesis does not happen at normal body temperatures. So with male mammals, the testes are going to need to be outside of the abdominopelvic cavity in order for spermatogenesis to occur. They have to be a little cooler in order for spermatogenesis to occur. So what's going to happen with this musculature is that generally when a male is cold, it's going to contract and pull the testes closer to the body. And when a male is hot, it's going to relax and pull the testes a little further away from the body. Also responds to fight or flight responses and stress and all that kind of stuff too. So that's the cremaster muscle, and that is the scrotum. Just FYI, if a male has an undescended testis, which is pretty common actually, most of the time the testes will descend through the inguinal canal from the abdominopelvic cavity 7 months-ish during fetal development. Sometimes they don't. Sometimes one of them doesn't. If it stays up in the abdominopelvic cavity, it's probably not going to do spermatogenesis because of the temperature. So if a male has an undescended testis and it's noticed immediately after birth, just because the scrotum has a single testis in it instead of two, you can go up and get it and pull it out. Sometimes males just never notice. Nobody ever notices. And for instance, we've had 80-something-year-old cadavers that have an undescended testis. They probably just don't do a whole lot of comparison between their scrotum and other people's scrotums, or it doesn't work. Yeah, the scrotum is still there and it's still the same size. It just has a single testis in it instead of two testes. And the male can still be fertile because they kind of overdo it with spermatogenesis anyway. Typically speaking, in a male ejaculate, 350 million to 500 million sperm. You don't need anywhere near that many to cause fertility. You can reduce 500 million by half, and this male will still have around 250 million sperm per ejaculate, which is within fertility ranges. It's the lower end. Might take a little longer to get pregnant, but it's still possible to get pregnant. Does that make sense? So, or to cause pregnancy, I should say. Well, it depends on how far up there it is. Sometimes if the inguinal canal is just not wide enough, you just have to go up there and pull it, and then it comes down. Yeah. Sometimes they have to actually surgically open up the inguinal canal and pull the testis down, right? But some men, it just stays up there their entire life, right? But it does cause fertility issues, at least potentially causes fertility issues. So, 350 million to 500 million sperm per ejaculate, which is within fertility ranges. It's the lower end. Might take a little longer to get pregnant, but it's still possible to get pregnant. Does that make sense? fertility, spermatogenesis, is not going to occur if, of course, both testes stay up in the abdominopelvic cavity. Okay, I think so.
It was on.
Yeah. Okay, so now to the testes. The testes are, of course, the male gonads, and they are homologous to what female structure? Yeah, okay. So they are homologous to the ovaries. Of course, they started up during fetal development. They started up in the abdominopelvic cavity, and they are going to move through the inguinal canal about 7 months. Fetal development is usually when they move out. So they're going to have some things, of course, in common with the ovaries. So let's look at them in a little bit more detail. First off, double functionality, just like the ovaries have. They both do spermatogenesis and produce sperm. And they also produce androgens, including testosterone. Testosterone has multiple functionalities, but to do an oversimplification of what testosterone and androgens are for is testosterone in an adult male is going to be responsible both for the development of the secondary sex characteristics, and the secondary sex characteristics would be all the things that happen in a male when he goes through puberty, right? So you have bone growth, increase in muscle mass, right? You have hair development, facial hair, axillary hair, pubic hair, all that kind of stuff. You've got the thickening of the vocal cords and the thickening of the larynx, which causes the changing of the voice. But then you also have all of the mental sort of aspects that come with sexual maturity. Testosterone in both sexes is responsible for sex drive, right? Typically speaking, male mammals are going to have higher sex drives than female mammals because the testosterone that females have, most of it comes from our adrenal cortex. It's weak sauce compared to testicular androgens. And in addition, males, of course, have more of it. Okay, so the gross anatomy of the testes. So let's sort of start talking about it. So this is a testis with the scrotum actually removed. I don't know if you guys, I don't remember if I put this in the lab manual or not. But the testis, in addition to the actual scrotum that surrounds it with the skin and the muscle and connective tissue that surrounds it, the testis also has a serous membrane around it that's represented here in pink. Both a parietal layer and a visceral layer of what they call the tunica vaginalis, not as in vagina, as in invagination. Invagination means fold. So this is this folded serous membrane. And what happens is when the testes descend through the inguinal canal, they actually take the serous membrane with them. And so they end up with a double-layered serous membrane around them and then fluid in between, which of course helps with lubrication, right? Okay, so deep to the double-layered tunica vaginalis, you run into the connective tissue. And this connective tissue is the same basic structure as it is in the ovary. It's called the Tunica Albugine. It's not a stretchy connective tissue, but in the testes, it's much thicker than it is in the ovaries for a couple of reasons. First off, in the ovaries, remember, you're going to have to bust through it to cause ovulation, right? So you don't need it to be as thick. And then, of course, the testes are more at risk because they're outside of the abdominopelvic cavity, so they need a stronger connective tissue around them. And then there's one other reason. The other reason is that the testes are actually really, really high pressure because there's so many seminiferous tubules inside them that they actually need a really strong connective tissue around the outside. So let's get into the inside and start talking. So this tunica albugine actually folds in and divides the testes into what we call lobules. So kind of like orange slices, yeah, with connective tissue in between them. But inside each one of the lobules is a super duper folded tube. This tube is called a seminiferous tubule. And the seminiferous tubule is going to be responsible for spermatogenesis. So much spermatogenesis. So we'll talk about that in just a second, but let's get the gross anatomical structures and we'll come back to sperm production in just a second. So these are called seminiferous tubules. We'll look at a cross-section of one in just a second. And then, so spermatogenesis is going to happen out here in the seminiferous tubules, but let's just follow the sperm out of the testis, right? It's going to occur in the seminiferous tubules, and then it's going to move through this guy right here, which is called the rete testis. Rete means net. A little testicular net, and then from there it's going to go into the epididymis, And the epididymis is where sperm maturation occurs. What do I mean by maturation? In order for the sperm to be fully functional, it not only has to have a tail, but it has to have a functional tail. So the mitochondria have to be attached to the flagellum to make it work, like a little outward motor, right? Then it also has to have a hat. And the hat is called an acrosome. And the acrosome is packed with enzymes that actually have the ability to burrow through the wall of the oocyte. Good? But acrosomes are species specific. That's one of the things that keeps cross-species fertilization from occurring. So generally speaking, the acrosome of a single species is only going to be able to burrow through the egg of that same species, with the caveat that if the species are super duper closely related, it might work, like a wolf and a dog. Yeah? Super duper closely related. Or a horse and a donkey, which can make a mule, but of course the mule is infertile, right? So you have to be super closely related in order for fertilization to actually occur. And that's sort of species specific with that acrosome. And we'll come back to that in just a second. Okay, so we had the tunica vaginalis, that was the serous membrane, and then the tunica albugine. The epididymis, which we started talking about, we'll talk about in just a second some more. And then how about the site of androgen secretion? So we know the site of spermatogenesis, it's all of these tubes. We'll get to that in just a second. Where do you make the testosterone and the androgens? You make them between the tubes. So if you do a cross-section of a tube, see one right here? These cells that are between the tubes are called Leydig cells or interstitial cells. Those cells are responsible for androgen secretion, but they don't secrete it into the tube. They secrete it and it gets picked up by the bloodstream. Yeah? Because androgens and testosterone are circulating in the bloodstream. That makes sense? So they're vascular and it goes into the bloodstream. So that is interstitial cells or Leydig cells. As far as blood supply and nerve supply to the testes are supplied by the testicular arteries, yeah, which are the same as the gonadal. So where do those branch from? Descending abdominal aorta, right? And then they're drained by the testicular vein, which drains either into the inferior vena cava or sometimes into a renal vein, right? It's a little variable there. It doesn't matter that much that it does that, but it usually does that. So they have autonomic motor innervation to the testes and sympathetic and parasympathetic innervation. And then they have lots and lots of visceral sensory innervation. And that visceral sensory innervation, especially on injury, brings us back to these guys. Okay, so the testes are really, really packed with seminiferous tubules, like surprisingly so. Like the first time I did a testicular dissection, I didn't realize how tightly packed they were. I sliced in, person was dead, it's fine, sliced into the testis with a scalpel. And those seminiferous tubules are so tightly packed in there that as soon as I opened it, they started squirting out and boop, right there in the eyeball, right? So I got squirted in the eye with a seminiferous tubule, and after that, every damn time, I wore goggles. I made sure that I wore goggles. So they're really tightly packed in there. So they're poppable, yes? Because they're super high pressure. So they need to really, really stop whatever the person is doing whenever there is a blow or an injury. Because you can reduce fertility by half by popping a single testicle. Right? That makes sense? Do you know anybody who's popped one? You do? You have some good stories. I have a friend who popped one. Go ahead.
He worked in a care center in a dementia ward, and one of the residents was scared. She was having a memory issue, and he was trying to help her get up and get into the bathroom, and she just crimped back and kicked him really, really, really hard.
Oh, that is so hard. That's a hard kick, man.
Yeah, he was 18, I think.
Oh.
18.
They will eventually repair, FYI. It's just going to be really, really terrible and uncomfortable before they do. They removed it?
But he still fathered 2 children.
Yeah, I mean, they overdo it with the amount of sperm that they produce, but I'm sure that was not a pleasant. And when I was in college, one of my friends was a skateboarder, and he was going down a rail and fell and popped his testicle open. So his they actually repaired it. It seemed to, I mean, I don't have direct evidence, but I think it was fully functional afterward. So yes, you have to be careful with them. I don't think that anybody has to tell the men in here that you have to be careful with them, but that's why, because they're super duper high pressure in there. Okay, so lots of visceral sensory innervation, especially upon injury. So let's talk about the whole.
I have a question.
Yeah.
Is it possible to retract them back,
All the way into the inguinal canal?
Because I've heard that there's in martial arts from Asia, from China, called Samsung. As Larry mentioned it, I was curious.
And you do martial arts, right? So
Yeah.
you heard that as, I wonder if that's an urban legend or if it's a thing. So, well, it's skeletal muscle that's involved in the cremaster muscle, but it's not like you can do tricks with them. So, I mean, there's not a whole hell of a lot of somatic motor control that's going on there. I mean, you can pull them close to home. I don't know.
There's a video clip that I watched.
A video?
Literally, the guy.
Okay. So, Mamadou, I don't know. My husband's going to wonder why the hell I'm reading about this weekend, but he's used to me by now. He's like, whatever. So I will look and see if it's an urban legend or if it's actually true. In some organisms, they can. I didn't know that it was at all possible in humans. It is possible in other mammals. They can go all the way back up into the body cavity, but I don't know the answer to that. I do like the interesting questions, though. Okay, so let's talk about spermatogenesis for just a second, because it's pretty damn interesting. Okay, so what is going to happen is spermatogenesis is going to occur in every single one of these seminiferous tubules. And if you look at a cross-section of the seminiferous tubule, what's going to go on from the outside to the lumen of the seminiferous tubule is going to be meiosis, yes? So you are going to have cells that are lining the outside of the seminiferous tubules that have 46 chromosomes. So important thing that we talked about before is that males will make more of those 46 chromosome cells throughout their life. So they're going to go through mitosis, yes? But then in addition, they are also going to go through meiosis. And as they go through meiosis, they're going to go from 46 to 23, and then they're going to reduce that to separate the sister chromatids, right? And then they are actually going to put the sperm into the lumen. So if you looked at it up close, what it would kind of look like is this. And I'm not going to test you on this in a lot of detail. But here's your interstitial cells, right? But here's the seminiferous tubule. And you're going to go through meiosis, and then you're going to dump that haploid sperm cell into the lumen of the seminiferous tubule, but you're going to do it with every damn section of the seminiferous tubule in every single one of those lobules. So it's completely excessive, the amount of sperm that's produced, right? So the amount of the sperm that's produced is way over what anyone would need to cause a fertility, although FYI, we have figured out that you, generally speaking, unless you do in vitro fertilization, fertilization is a team effort. The sperm kind of have to team up on the egg, and then one of them just gets to go, right? They're like, oh, we're taking down the defenses, and then one of them goes in. So it's not like one sperm, one egg actually can cause fertilization most of the time. They actually have to kind of gang up on it. So
Is it ever possible for more than one?
it is, but it will cause chromosome abnormalities, generally speaking. And usually those won't be, I mean, with a few exceptions, they usually won't be retained past the first trimester if more than one of them then get in there, because you would have, 46 plus 23, 69 chromosomes, and that's not a viable chromosomal alternative. So you guys have seen sperm before, but here's your little sperm, right? And these are human sperm. Sperm are interesting because there are different shapes for different species. Not only is the acrosome different, but the swimming mechanism is different and the shape of the sperm is different. Notice that it's really, really tiny. An egg, by the way, a human oocyte, is big enough to be visible with the naked eye. It's about the size of a 12-point font period. So you can see it with the naked eye. These are super duper tiny. There's not a whole hell of a lot there, except for packaged DNA, right? And the mitochondria to run the flagellum. Everything else other than the male's DNA is provided by the egg. The egg has all of the mitochondria. Male mitochondria doesn't even get in there. It's got all of the other stuff that's necessary, and this is basically just providing the DNA from the male. Okay, so let's look at sperm and semen conducting structures. So some of the stuff that we have talked about is like the way that these words get used interchangeably and that they shouldn't, right? So sex is not the same as gender, and we now, of course, know that the vagina is not the same as the vulva. But now let's talk about the fact that sperm is not the same as semen, okay? So sperm is the little haploid swimmy cells, yeah? Okay? But semen is the entire volume of the ejaculate that includes sperm. But it also includes the secretions from the prostate gland, yeah? The seminal vesicles, and although it's secreted prior to ejaculation, it ends up in the ejaculate, the bulbourethral glands, right? So sperm and 3 secretions is semen. So, and generally speaking, FYI, sperm alone in humans will not cause fertilization. You actually need the entire components of semen to cause fertilization. Now, in the in vitro situations, yeah, you can bypass all of that, and you can actually inject the sperm directly into the egg. But in normal in vivo situations, you need all of the components of semen in order to cause fertilization. Okay, so the sperm and semen conducting structures. So if we start down here, we say, okay, the site of spermatogenesis was inside the seminiferous tubules, right? But then what they do after that is they move from the seminiferous tubules to, one more time, the rete testis. Then they are going to move out these little guys, which are called the efferent ductules. Then they're going to move into the epididymis. It takes about 20 days for maturation to occur in the epididymis, and it goes head, body, and tail. And then males actually don't ejaculate sperm from their testes. They have to ejaculate the sperm from the epididymis, because what goes on in the epididymis is the maturation process. When they were dumped into the lumen of the seminiferous tubules, they had tails, but they didn't work. Right? So they start actually working, and they didn't have a functional acrosome. So as they go through the head, body, and tail of the epididymis, down at the distal end down here, that's when they're ready to be ejaculated, right? So again, in situations in which you're having a couple who's dealing with infertility, they can harvest the eggs directly from the ovaries, yes? But do they generally harvest sperm from the testes? No, what they get is they get semen, right? With mature sperm that was ejaculated and actually has all of the other components in it. They don't actually do a surgical intervention in which they actually take this. I mean, there have been situations in which they do, but that's not usually how fertility treatments go on with couples. Does that make sense? So the epididymis actually contains a really long tube. If you stretched out the tube inside of the epididymis, it'd be about 4 to 5 meters long. And it's maturing all the way as it goes through there. Is lined with ciliated cells. And then this is the first place, but definitely not the last place, that you actually have smooth muscle that will contract upon ejaculation. So one of the things that we will see is that when a male ejaculates, there's smooth muscle contraction that occurs all the way down in the epididymis, all up the Vas Deferens, through the ejaculatory duct, and through most of the actual urethra. So all of that sort of pushing it out. All right, so what about unejaculated sperm? What happens if a male does not ejaculate? You just reabsorb them. They get reabsorbed into the epididymis, they get reabsorbed into the testes. There's nothing particularly harmful about a male not ejaculating regularly. And generally speaking, it's not healthy or unhealthy to ejaculate regularly or not, with one little exception. And that little exception is that generally males who ejaculate regularly have healthier prostates. So the prostate seems to be healthier with regular ejaculation, but other than that, nothing particularly important about it. Good? Okay. A decreased likelihood of prostatitis and a decreased likelihood of prostate cancer, but only slightly. Okay, so now, of course, we are going to leave the epididymis and go up the Ductus Deferens or the Vas Deferens. And the Ductus Deferens, of course, is going to go up through the inguinal canal in what we call the spermatic cord. And the spermatic cord contains all of the stuff that is going to and from the testes, both the muscle, the testicular artery, the testicular vein, the vas deferens, and the nerves that are going to and from there, right? And so the sort of pathway of the vas deferens is a little weird. So it goes up through here, and then it wraps around behind the urinary bladder, right? Okay, and it's going to join with the seminal vesicle, and eventually it's going to dump into the ejaculatory duct. So let's talk about that. So the Ductus Deferens or the Vas Deferens, so it goes up and it wraps around. The Ductus Deferens also has a thick, smooth muscle layer in it that is going to contract upon ejaculation. The ejaculatory duct, if you look at the back picture, so this is a posterior view of the male reproductive tract. So the portion where it ends, so here's the ureter, it kind of wraps around. This broad portion right here, which is the end of the vas deferens, is called the ampulla of the vas deferens. And then what it's going to do is it's going to join that, which primarily brings sperm with the whatever fluid they were swimming in, right? And it's going to join with the seminal vesicle and dump into the ejaculatory duct. It's hard to see what it actually looks like from that side, so it's better to actually look at it from this side because you can see the ejaculatory duct dumping into the prostatic urethra. Okay, so let's talk about vasectomies. So what it is, what's involved there, it is one of the many ways that you could do contraception. It's relatively permanent, but it has about a 50% reversal rate for males who want to reverse it. Tubal ligations, by the way, which is cutting the oviducts or fallopian tubes, has a really low rate of reversal because the egg is big to begin with. And if you scar the tube, which is already relatively small, it's really hard to actually rejoin the fallopian tube without the scar tissue causing infertility. But in males, of course, sperm are really, really tiny, right? And you don't need as many of them as you have. So it has about a 50% reversal rate with vasectomy. So what they do with a vasectomy, and you guys know how this works, I imagine, is they open up the spermatic cord, usually right near the body wall. And all they do is they cut, cauterize, tie, or suture both vas deferens. Importantly, for people to understand is that the male will still produce semen upon ejaculation. It just won't have sperm in it. Yeah? Does that make sense? And the volume of sperm in the semen is relatively small, so the volume won't even be dramatically changed. It just won't actually have sperm. One of the important things to understand, and if you get this done, they will definitely explain this to you, is that right after a vasectomy, sperm can live in the tubes for quite a little while afterward. So you actually have to use another form of contraception until the male has ejaculated multiple times. And they usually say weeks to, what did you say?
3 months.
3 months? What? So one of the questions that, I don't think it was in this class, I think it was in the last class.
3 months, and we call it flushing the system in surgery, is what we call it. You flush your system at least 3 times a week.
3 times a week for 3 months.
Yes, for 3 months.
Interesting. Wow. And so you have to use another form of contraception for 3 times a week for 3 months, unless you're by yourself. So then you don't.
Even though they still come back with dead sperm in there.
Interesting.
But they'll still have dead sperm, so we tell them you still have to keep using
Contraception.
birth control,
Yeah.
and retest it in like 3 weeks or
So one of the guys in the first class, super duper young, really, really curious, wanted to know if it was possible at all for a male to actually cause a pregnancy when he didn't ejaculate. And the answer is yes. Absolutely. If you have ever ejaculated before in your history, ever, then whatever fluid leaves might very well have viable sperm in it. And it does, even with the pre-ejaculate. Just so, and the reason that's important for us to know is not because I expect that you guys don't know it, but because they don't actually teach that in Utah. They don't actually teach anything about contraception, anything about avoiding pregnancy. It is absolutely possible, and sperm live in there for a long time. They are hardy little buggers, and they're not really doing very much. They don't have a really high metabolism. They don't really need very much. And we will see that the semen actually gives them everything that they need to last for quite a while. So, all right, so vasectomy. So sperm is still produced, but it doesn't actually make it into the penis. There's about a 50% success rate. But let's talk about what just happened 2 weeks ago. 2 weeks ago, did we talk about this already? The Indian equivalent of the FDA just approved this male birth control, which was semi-permanent. It's reversible. And it's approved right now, and so people are going to start using it. I'm super duper excited about this possibility because what they do is they give a local anesthetic, right, to the scrotum, and then they inject a gel into the Vas Deferens, and the gel solidifies into the Vas Deferens so that the sperm can't make it through the Vas Deferens. And it stays in there for up to 13 years. But it's reversible with another injection, yes? And the males that they have been trying it on in clinical trials were fertile within a month after that reversal. And as a mom of a boy, I am so happy about this possibility. I am so, like, by the time he's 18, if it pans out really well, I'll be like, I will hook you up, brother.
So, if the sperm is joining the semen in the seminal vesicle, is it in another kind of fluid?
It's just basically extracellular fluid, just enough so that it can swim through the tube.
So
Not
that's
anything
in
particularly.
blood.
Yeah. Yeah, that's not a big deal. So anyway, that'll be interesting to see what happens in India with those sort of longer term studies and the males who try to reverse it and have it successfully reversed. Because of course you don't want to make permanent decisions about fertility when you're 16, right? But you also don't want to make permanent pregnancy decisions about fertility when you're 16. And trust me, I am the child of a mother who was 16 and she didn't know what the hell she was doing. I was raised by wolves. Go ahead.
Did it say in that study what the effective rate was for the ones that are doing it?
Same as vasectomy, above 97%. Yeah, above 97%, which is just, I mean, it's pretty tremendous. And of course, there's going to be a lot of resistance to that, right? Until there isn't, right? Until there isn't a lot of resistance. Think about all the freedom, though. I'm thinking about my kid going to college and being like, I'm cool. I'd be like, you have fun. Here's some condoms. Okay, so we already did the male urethra, so it's the same portions whether we're talking about it in reproductive functionality or we're talking about it in urinary functionality. So we have prostatic urethra, membranous, spongy or penile, and then the external urethra orifice. And we already talked about the spermatic cord, but what we didn't talk about is an inguinal hernia. So inguinal hernias are not unique to males, but they're definitely more likely in males. Because what basically happens, of course, when the testes descend through the inguinal canal is it widens the inguinal canal, yeah? And so what can happen in males more likely than females, but in both potentially, is that if anything really, really increases the pressure in the abdominal cavity and you already have a weaker or a bigger inguinal canal, then what can happen is you can push something through the inguinal canal that wasn't supposed to go through there. And it's not comfortable. It could be a bit of mesentery, it could be a bit of intestine, it could be a bit of anything. So it can be really painful. It's usually reparable. You can usually just stuff it back up there, and if it happens again, you can put in a piece of mesh that will prevent it from occurring. But they're definitely not comfortable. And they do occur in women as well, but not as frequently, just because our inguinal canals aren't bigger. It's just when something gets pushed through that hole. Okay, so penis. So the external anatomy of the penis, first off, the dorsal side is the other side, right? This is the ventral side of the penis. So the external anatomy of the penis, the portion where it's actually attached to the body, this is going to be the root where it's actually back behind the body wall. And of course, this is just shaft of the penis, and this is the glands of the penis. Now, the penis isn't exactly homologous to any female structure because it has homologous structures within it from 3 different female structures. So the glands of the penis is homologous to what? The glands of the clitoris, yes? But the erectile structures within the penis go different places in the clitoris, right? The paired corpora cavernosa are homologous to the corpora cavernosa, right? But the skin covering the shaft of the penis is homologous to what structure in the female? Labia minora, exactly. And then the corpus spongiosum here, right here, that's actually homologous to the bulbs of the vestibule, which end up lateral to the vagina. So the penis itself is not homologous to any female structure. It's homologous to like 3 or 4 different female structures, and they all end up. Does that make sense? Okay. So not directly homologous to any of those. Okay. So let's talk about the prepuce of foreskin, and let's talk about circumcision. And then we'll talk about how erections actually work. So the prepuce of foreskin of the penis, where's the picture go? There it is. Okay, so this is the original anatomy. Okay, the original anatomy is that the glands of the penis, like the glands of the clitoris, has a partial covering, which is protective, and it's called the prepuce, and it's homologous to the prepuce of the glands of the clitoris. And so what happens, still more frequently than not, but getting less and less common in the United States, is circumcision. And let's talk about the history of circumcision. Let's talk about whether it's medically necessary. Don't talk about it with people online, because they will tell you that you're a monster or an idiot or both, basically. But still, it's time to have conversations about whether we should be doing this anymore. Okay, so clinical connections in the U.S. Around 60% of males are circumcised. It is not the case in other portions of the world. Circumcision is not common in other portions of the world, in most other portions of the world. It's actually less common than it is here. So let's talk about how it occurs and then the history. Okay, how it occurs now in the United States, anyway, is that usually immediately after birth, if the parents decide to do so, they will, by one mechanism or another, do an incision to remove the prepuce, or they could do a ligature, which actually reduces blood flow to the prepuce and will actually fall off quickly thereafter, within a couple weeks thereafter. Why? Historically, if you go way, way back historically, we have to deal with the fact that between the prepuce and the glands of the penis, when the prepuce is still present, there is a secretion that is produced, and that secretion is called smegma. That's where that word came from. So if a male has good hygiene, then that's not an issue. If a male doesn't or couldn't historically, for instance, have access to running water and good hygiene, then the buildup of that fluid, or it's actually a waxy secretion, is really, really hospitable to pathogens. Okay? So historically speaking, they would remove the prepuce because it was less hospitable to pathogens and you were less likely to get infections associated with it. And then, of course, it became a cultural practice. Yes? Then it became one of the cultural shibboleths or identifiers of Judaism, right? So if you were of Jewish descent, then your males were circumcised. And then, of course, Christianity came out of there, and a lot of the practices went into lots of Christianity. And then it sort of extended as a cultural practice that we didn't really question for long periods of time. But now we at least have the information to figure out what the impact is and whether we should be doing it. First off, the American Association of Pediatrics no longer recommends circumcision, and many, many insurance companies no longer cover circumcision. So let's talk about the whole idea of medically necessary. Is it medically necessary? It doesn't seem that it is. It seems that hygiene is medically necessary. Yes? And most of the benefits of circumcision can be had by proper hygiene, which can be taught to a little boy just like you would teach hygiene to a little girl. No particular problem. You're going to have to take care of it for them for a little while, and then eventually you won't, right? So now, these are some things that are commonly claimed to be benefits of circumcision still. Reduction in penile cancer. We have figured out that hygiene is as much a reduction in penile cancer as circumcision. We have also figured out that UTIs are less likely to occur either in someone that is circumcised or in someone that has proper hygiene. Seems to be about the same. STDs, less likely again in both situations with one exception. And the one exception is that circumcised males who are exposed to HIV are less likely to contract HIV than uncircumcised males. They're also less likely to pass on HIV. It's not dramatically different, but it is the one thing that we do see that actually gives one advantage. The other thing is that, has anybody ever seen it done? Yeah, I've seen it done too. Sometimes they don't use anesthetic on the little boys. Yeah, and even when they do, it's an injected anesthetic into the penis, which is almost as bad as the circumcision is itself. So sometimes they don't use anesthetics. It's pretty harrowing to experience, honestly. And the other thing, and this one is something that we didn't even talk about for long periods of time, but is worth addressing. Unfortunately, we don't have a really good double-blind kind of study about this. So what happens is the clitoris has about 8,000, the glans clitoris has about 8,000 nerve endings. The glans penis seems to have fewer. They say 4,000 to 5,000. Don't know why. But what happens is it's a really, really sensory structure, not surprisingly, right? So what happens if, for instance, you take this really, really sensory structure and you actually remove the protection of the sensory structure long before, of course, the male is sexually active. Long before, right? In infancy. And then you have this really sensory structure that is having, being rubbed against your clothing for your entire life before you become sexually active. Does that make sense? Okay. Then you get a reduction in sensitivity. That's what the nervous system does. If you have constant stimuli on sensory, then you're going to have reduction in sensitivity. So for the women in here, imagine that if the glans clitoris were not covered with the prepuce and was constantly rubbing against your clothing for your entire life. So this reduction in sensitivity is something that no one has a direct comparison about, unless, of course, they were circumcised in adulthood. And there are a few males who choose to be circumcised in adulthood and do report to us that the reduction in sensitivity is dramatic that occurs with circumcision. Go ahead.
I talked to a gentleman that was older and he had, I think, in his 30s, and he said it was
A huge difference in reduction in sensitivity. But of course, I mean, the only reason to talk about this is because the boy, the infant, doesn't make this decision, and so people are arguing about it right now. And it may seem relatively arbitrary, but perhaps it's not relatively arbitrary. Perhaps we need to rethink what we're doing about this. And as it becomes less and less common, right, then you have the other cultural pressures that are also going to be removed. But anyway, people get bonkers about this subject. Don't even bring it up with somebody unless you want to argue with them. Don't talk about it at the Thanksgiving table. Okay, so that's circumcision. Now let's talk about the internal anatomy of the penis. So if you look at the internal anatomy of the penis, this one, of course, you're seeing the erectile structures here. And the metaphor that I used about the pool float, and you can kind of see how it works with the hydraulics here, because the root of the penis and the erectile structures are kind of smashed back against the body wall, and those aren't movable. So when you get an increased blood flow, what's going to happen is you use this as leverage, and then it causes an erection. The same thing happens in the clitoris, but guess what? Nobody has ever published this cross-sectional anatomy of the clitoris. It's still not out there. So the cross-sectional anatomy of the penis helps us to kind of understand how the erectile structures work. So this is, of course, the dorsal surface of the penis and then the ventral surface of the penis. The blood flow comes in primarily through the dorsal surface, and then you've got these central arteries. And the way that it works basically is that when a male is aroused, or whatever the male has, or whatever reason the male has an erection, what's going to happen is you have arterial dilation leading to the penis that fills up these spongy venous spaces. And as you fill up the spongy venous spaces, what they do is they press on the veins that would drain. Does that make sense? And so you end up trapping the blood in the penis that causes an erection, right? Until, of course, the male ejaculates or the erection goes away. And then you remove the pressure on venous drainage, and then the veins can drain. Does that make sense? So that's basically how that actually works. So basically what we have is paired corpora cavernosa, right? Okay. And then the corpus spongiosum that is around the urethra, and then nerves and blood vessels actually going to it. And if you look at a cross-section of the penis, it looks kind of like a monkey face. See the monkey face? Or, of course, looks like Kanye. Coincidence? I think not. He chose those glasses. We get to make fun of him. You know we do. Okay, so blood vessels that deliver blood to the penis are branches off of the internal iliac arteries, and the nerves are autonomic motor nerves from the pudendal nerve, and also, of course, lots and lots of sensory innervation that goes back through the pudendal nerve. Okay, so now let's look at the accessory glands, and then we'll come back to erection and ejaculation at the very end. So accessory glands that make the rest of the components of semen. This I find really interesting, especially since it's so species specific. So semen is, of course, sperm plus the secretions of 3 glands, yeah? And so the first glands are these guys right here, which is the seminal vesicles, right? And from a posterior view, the male reproductive tract kind of looks like an angry mosquito. You got eyes, eyebrows, big long proboscis. So seminal vesicles are paired. They're on the posterior side of the bladder. They dump into the ejaculatory duct, right, which will join with the prostatic urethra. They are lined by secretory epithelium. They have smooth muscle in their walls. So when the male ejaculates, what happens is the smooth muscle pushes the secretions into the ejaculatory duct. And then they've got a fibrous capsule around them with dense connective tissue. Most of the volume of semen actually comes from the seminal vesicles. They make about 60% of the volume of the fluid in semen, and they actually deliver the nutrients that the sperm needs to swim. Sperm like fructose better than anything. They also deliver the rest of the nutrients they need. Interesting other stuff that they found recently that semen has in it, though. They have some prostaglandins that, when it hits the cervix, the prostaglandins actually cause cervical dilation, which increases the likelihood of fertilization. Does that make sense? So cervical dilation. It also, and this is weird and interesting too, there are also immunosuppressant chemicals, but they primarily, of course, they are going straight out of the male, they're going into the female, yes, the immunosuppressant chemicals, and they help protect the sperm against the hostile vaginal vault so that the sperm can keep going. But they also make it far more likely that if a male to female transmission of STDs and STIs. Yes? In addition to sort of the fact that the semen's going to come into contact with a mucous membrane in the females, and it's not a mucous membrane in the males. I mean, you get to a mucous membrane, but it's not all a mucous membrane. They also have immunosuppressant chemicals associated with it. And then there's some enzymes in there, and then this one's kind of interesting. Have you guys ever seen like the 2020 specials in which they shine a UV light around a hotel room? Because you don't want to see it. Oh, heavens. So it's just anecdotal. It's not particularly important that semen fluoresces under UV radiation, but we do use it in forensic situations to find semen. When I was in college, part of how I put myself through college was I was a bartender and a waitress, but I also worked in a DNA fingerprinting lab. And so mostly we did DNA cases from, mostly paternity cases most of the time, but then we also every once in a while, of course, had violent crimes, rapes, murders, and that kind of stuff. And then every once in a while, somebody would just walk in to the lab off of the street and say, here's my wife's underwear. I want to know if she's been cheating on me, see if there's semen on it. And I literally would go in the back and shine a light on it and then charge them $350. Because that's all I have to do to tell whether it's semen. You just shine a light and the whole thing fluoresces. So like they turn off the lights in hotel rooms and shine it around and there's semen everywhere. It's crazy. How the hell did it get up there? That's what I'm wondering. But then the next question, of course, that the man had was, is it mine? And then that's another $750, which is, I mean, I think therapy and maybe conversations are a little cheaper. But so anyway, so we could test the DNA, but he would have to pay for that out of his pocket. So anyway, it fluoresces under UV light. And then we have the prostate gland, and the prostate gland adds some other things to the semen. The prostate gland, of course, wraps around the urethra. Hopefully you guys have figured this out, but can you see why prostatitis actually causes problems with urination in males? Because if the prostate is inflamed, it actually sort of compresses the prostatic urethra. And so even if the urinary bladder is full and the internal urethral sphincter is open and the external one is open, it's still hard to get it out. So that's prostatitis. So it has secretory cells and smooth muscle and a fibrous capsule. It makes about another third of the volume of semen. Notice we're up to 90% here, right? That's without the sperm. And the fluid that comes from the prostate is that opaque fluid, cloudy, milky fluid. It's got citric acid in it, which the sperm likes. It's got an antibiotic chemical to combat UTIs in males. It helps to cleanse their urinary tract. It's got enzymes that enhance sperm motility. But it also has enzymes that make the semen stay liquid until it hits the vagina. And then semen stays behind in the vagina. Only sperm swims past the cervix. So it should stay liquid until it hits the pH of the vagina, and then it should stay back there, and then the sperm keeps going past the cervix. That makes sense? So it's supposed to be liquid, and then it's supposed to clot. Okay, now the prostate gland is really, really susceptible to inflammation. We do not know why. It's also, if you have a male who has recurring STDs and STIs, a lot of times they will be housed in the prostate gland and they sort of recolonize, and housed in the prostate gland and recolonize. So you can have what's called benign prostatic hyperplasia, also susceptible to cancer, susceptible to STDs. Let's talk about a prostate exam real quick. So how's a prostate exam work?
Back door.
Yeah, up the back door, because the other option is just as unpleasant. I don't know if it's just as unpleasant, but it sounds pretty unpleasant. The other option is to go up the urethra.
Long as
Right.
it's not your finger.
And so what they do is once you get into your 40s, and they will definitely start by age 50, is that you will have to have a regular prostate exam, which nobody thinks is particularly pleasant. And what they will do is they will actually insert a finger up the anus, gloved, to feel to see whether the prostate is inflamed. And it's important to know that because prostate cancer grows slow in the beginning and then really, really quick. So if you can catch it early with regular exams, you're more likely to survive. So sounds really unpleasant, probably is really unpleasant. My husband is not looking forward to it. So the bulbourethral glands, you already met those, but let's revisit them. They're right here, also called Cowper's glands. They are homologous to what glands in the female? They're called the greater vestibular glands, the ones that lubricate the opening of the vagina upon arousal. So these are responsible for producing that lubricating mucus during sexual excitation prior to ejaculation, and it cleanses and neutralizes the urethra, and it also lubricates the tip of the penis upon arousal. They call this pre-ejaculate. That's what that stuff's called. Okay, and then last but not least is, go ahead.
So the main point of prostate is just to make those additional fluids that
Yes.
make it
Mhm. Yeah. And so, by the way, let's talk about male infertility for just a minute. So anything wrong with any one of those glands can be responsible for infertility just as much as lack of sperm. So all of the components of semen have to be Goldilocks right in order to have a male be fertile, right? And so you could have low sperm count that could cause infertility. You could have low sperm motility, which might have to do with what's not being secreted or being secreted improperly from the seminal vesicles. You could also have, for instance, the semen should clots before it actually gets to the vagina, right? Or doesn't clot properly in the vagina, and then you actually get things that irritate the lining of the uterus and can cause fertility problems. So all of the things have to be pretty close to right. So once again, when a male, if a couple is going through fertility treatments, they need semen. They don't just need sperm. They need all of it, right? So the semen has to be there. So they will use male semen. In certain situations, they can actually isolate the sperm and do in vitro fertilization, but a lot of times they'll actually use the whole semen in the initial stages, and it has to be ejaculated, it has to be fully functional. Okay, so last but not least, and this is the very last of the stuff, and I'm not even going to do the lymphatic system. So you guys are actually going to finish, and the other class is going to have to come on Monday, and you guys don't. Okay, stages of the male and female sexual response. So not surprisingly, there are a lot of parallels, right? Because we have a lot of homologous structures. Interestingly, I don't know if you guys have noticed this, because I don't know how many of you guys ever read your book. Your book has an entire discussion about the phases of the male sexual response, and not a single thing about the phases of the female sexual response. Even though one of the authors, Valerie O'Loughlin, is a colleague that I see all the time at professional meetings. And I asked her last time, I was like, WTF? And she's like, oh, well, it's just generally not covered in textbooks. And I was like, let's be the change. So I'm going to be the change. Okay, so stages of the male and female sexual response. The female is not as well understood as the male. There are some things that we do understand about it. Interestingly, of course, a lot of it is not external. Yes? So you don't see the stages of the female sexual response as much. And of course, the female climax is not necessarily necessary for fertilization or implantation, right? So it's not directly related to fertility and procreation, so it kind of gets left off. So what kind of research has gone on? not very much research has gone on into the female climax. And some of it was actually done. Did you guys know that Masters and Johnson did some of this? You probably learned this. So Masters and Johnson in the late 1950s, early 1960s, I think, decided that they wanted to know lots and lots of things about sexual practices and about sexual anatomy and sexual physiology. And so in addition to doing lots and lots of surveys, they also brought people in the lab and watched them have sex. And they took cameras and they made a camera that was shaped like a penis, brought her into the lab and videotaped what went on inside her anatomy. Those kinds of things do not get funded very frequently, and definitely not in Utah, right? So we do not have as much research as about the female sexual response as we do about the male sexual response. But it is anatomical and physiological. So what do we actually know? Okay, so there are multiple stages to the sexual response in both sexes. There's the arousal and plateau stages. Those usually kind of run into each other and generally accompanied by erection. And then there is the climax stage, and the climax stage in a male is usually accompanied by ejaculation, and a female is usually accompanied by climax, which is muscular contraction. Sometimes ejaculation occurs. And then there is potentially a refractory period. The period after the climax in which you can't have another climax doesn't actually exist in females. And then there is the resolution stage, and the resolution stage is just after. So let's look at the similarities and differences between the sexes in these. So the arousal and the plateau stages, in both sexes, these are common. The nipples become erect. There is what's called the sex flush, and the sex flush is really interesting. The sex flush increases blood flow to your cheeks, makes your lips swell, and makes your eyes dilate. Heterosexual men find that very attractive. So what you can do in pictures to assess that is just take the same woman and manipulate a photo of her so that her lips are a little more swollen, her cheeks are a little redder, and her eyes are dilated, and then ask males repeatedly over and over until they're exhausted to assess her sexual attractiveness. And you figure out that males, heterosexual males, tend to be attracted to women who have what's called the sex flush. So, ladies, putting on makeup, you think you're trying to look pretty, but you're trying to look horny, which is the same thing to a heterosexual male, okay? So you're trying to make your eyes look a little darker. You're trying to make your lips look a little darker and your cheeks look a little darker. There's no difference. You also get in both sexes, oh, by the way, women don't tend to necessarily find that attractive. You can manipulate the male face to make the sex flush, and it's not dependable whether women find that attractive. What they do tend to find attractive is if you change the male facial features so that they have what looks like more testosterone. So you can increase the thickness of the brow, increase the thickness of the jaw, increase the thickness here, increase the amount of musculature in the face. Heterosexual women tend to find that more attractive, more sexually attractive, as reported by their own input. Okay, increased heart rate, increased blood pressure, increased muscle tone, and hyperventilation. Not hyperventilation meaning you're going to pass out, just faster rate of ventilation. Good? Okay, so what is different, males and females? The female is also characterized by what we call vasocongestion or erection in the bulbs of the vestibule, and increased blood flow to the labia majora. And then the glands in the corpora cavernosa of the clitoris swell to 2 to 3 times their unaroused state. The lower 1/3 of the vagina actually constricts. The smooth muscle in the wall of the vagina actually constricts. And then the uterus changes position. And this is interesting. This is one of the things that Masters and Johnson figured out that nobody knew, is that when a woman is aroused, her uterus goes from being folded over to being pulled back. And it changes position this way, and then it pulls back a little bit. So the vagina tightens and the uterus folds back and pulls back. And it won't stay there the whole time. We'll talk about that in just a second. The cervix kind of withdraws from the vagina. The vagina becomes reddened and moistened because of the secretion of the greater vestibular glands and the increased blood flow. And the opening of the vagina becomes lubricated. Okay, and then in the male, kind of parallel, the bulbourethral glands, of course, are going to secrete fluid to cleanse the urethra, lubricate the penis, change the pH. And then male arousal is generally characterized by erection. And this is an increased blood flow to and a decreased blood flow back from the penis. This is a parasympathetic nervous system response, meaning that if fight or flight is engaged, what it does generally is constrict the arterioles leading to the penis. And so it's inhospitable. Stress is relatively inhospitable to erection. Okay, it ends up becoming an issue with erectile dysfunction that we'll talk about. Okay, so how erection occurs. The arterioles leading to the central arteries, these little central arteries that we talked about before, the arterioles leading to these right here dilate due to parasympathetic stimulation, or a lack of sympathetic stimulation, I should say. And the blood flow to the penis is increased about 6 times above normal. Central arteries fill, and then the venous spaces fill, and then they actually compress the veins that would drain the penis. This progresses until you reach the limit of expansion of this particular penis, which is determined by this not stretchy tunica albugine again. It is dense, irregular connective tissue, and when it is full, and that's as big as it's going to get. That's just the limits of the size of that particular erection. Good? Okay, so the loss of erection. Erection will fade when the arterioles constrict, decreasing the inflow of blood, which will eventually stop putting pressure on the veins that drain the penis. The loss of erection can be due to a decrease in sexual excitement, ejaculation, increased stress, anything that changes the blood flow to the penis. So let's talk about erectile dysfunction in just a minute. So erectile dysfunction is defined as the inability to either achieve or maintain an erection. We thought for years, decades, that it was psychological exclusively, but it's cardiovascular, so it's very likely to be anatomical, physiological, and then it will get a psychological component potentially. Around 70% of cases recur because there's something wrong physically. And this is important for us to consider as Americans because we do not take care of our cardiovascular system. Okay, if you start gunking up your vessels, you know, of course, that can cause a heart attack and a stroke. We all know that, right? But it can also lead to erectile dysfunction because you need nice open arteries in order for erections to occur continuously and dependably, right? So erectile dysfunction affects 2% of men under age 35, 10% by age 55, 50% by age 75. A lot of that they think is down to cardiovascular fitness. Cardiovascular fitness decreases as you age. Now, why did people think that it used to be, why did people tend to think that it was psychological? Well, because if erectile dysfunction starts occurring, then the sympathetic nervous system stress response does not help the problem. Does that make sense? Because the sympathetic nervous system will decrease blood flow to the penis. And so regardless of the initial reason for erectile dysfunction, stress is inhospitable to erections, right? So we actually don't, interestingly, deal with erectile dysfunction in women. But does it potentially occur? But does it actually stop them from having intercourse? It doesn't. Now, the same erectile dysfunction drugs that males use to treat erectile dysfunction or make erections more likely actually do work in women. They can increase blood flow and increase erectile structures. A lot of women don't even think that that's a possibility or even consider whether they would use it. Okay, so what causes the original erection? The original parasympathetic impulses leading to arousal could be from cerebral cortex. You think about something that you find enticing. REM sleep. Nocturnal erections occur many times per night. Or spinal reflex. Spinal reflex basically just says if something touches your penis, you might actually have an erection as a response. But your brain can override the spinal reflex. Like I said, fear of failure, stress, any other anxiety causing sympathetic stimulation can override what was going on with the erection. So it can cause constriction of the arterioles. Okay, so climax stages. In both sexes, the sex flush continues to the climax stage. In both sexes, the perineum, the pubococcygeal muscles around the urogenital diaphragm will have contraction, okay? Skeletal muscle contraction in the perineum. And interestingly, especially, we know this especially because of like spinal cord patients, the climax is both happening in your reproductive organs, but it's also happening in your brain. So a large part of what's going on and the reason people seek out one climax after they've had another one is because of what goes on in the brain. It is a big freaking party of all of your favorite chemicals released all at once. And they are, for instance, intense pleasurable feelings related to the release of endorphins. Endorphins are pain relievers. They make you feel kind of 10 foot tall and bulletproof. Opioids actually pretend that they are endorphins, so you get a little shot of that for a minute. You also get dopamine. Dopamine is your reward neurotransmitter. Dopamine is what your body releases when it wants you to do something again in the future. Oxytocin and vasopressin are two hormones that are really interesting. These hormones are released in different proportions in males and females. They are bonding hormones. And they're related to other functionality as well, but in this particular functionality, what happens is oxytocin is pair bonding. Vasopressin tends to cause territoriality. Male mammals tend to release more of one, and females mammals tend to release more of the other. I'm sure that you can guess which one. Guess. Male mammals tend to release more of vasopressin, which increases male-male aggression and increases territoriality. It also causes a kind of bonding, but it's not that's my boo bonding. I call it that's my bitch bonding, right? It's like pee in a circle around them, okay? Oxytocin causes pair bonding, and females tend to release more of those. Now, that's just overall. Individuals, incredibly variable in what they actually release. So what happens with the female, and then we'll come back to oxytocin and vasopressin for just a second. So what happens in the female upon climax is this uterus was tilted backwards and the cervix was pulled back. But when the female has a climax, the cervix pushes into the vagina and pulls back. What do you think's happening there? Push in, pull back. Yeah, it's sucking up the sperm into the uterus to make fertility more likely. So it causes peristaltic waves of uterine contraction as well, again, trying to get it going that direction. And involuntary pelvic thrusting happens in both sexes. So females who do climax are actually more fertile than females who don't climax. It's not demonstrably so, otherwise we would never have involuntary pregnancies or sexual assaults causing pregnancies, but statistically, you are more likely to have fertilization if the woman has a climax. Then let's talk about female ejaculation. What the hell's going on there? How often does it occur? We still don't know. So female ejaculation, when it occurs in the women who have it, what happens is it's usually due to stimulation of what we call the Grafenberg spot, and people argue about how many women have those. They call it the G-spot. It's an area of ridged tissue on the anterior wall of the vagina that usually isn't even detectable unless the woman is aroused because it changes the texture upon vasocongestion. And people are still arguing about this even in the scientific literature. There's an entire group that says it absolutely never exists, and there's an entire group that says, I don't care what you say. So, if so, how many women? When it occurs, what it is probably secretion of these paraurethral glands that are homologous to the prostate gland. And again, it goes into the distal region of the urethra and not the vagina, which is confusing as hell for women who have no idea what the hell could possibly be going on. They think they just peed themselves. But of course, upon testing, they figured out that it has high concentrations of prostate-specific antigen. And usually in women who have this female ejaculation, it's because of stimulation of the Grafenberg spot, specific to certain types of stimulation. Okay, and in women, they have all of these same chemicals released, only the proportions are different. More oxytocin is released than vasopressin. So let's go back to this and talk about sexual evolution and why it's a good evolutionarily stable strategy for females to pair bond strongly and males to not pair bond as strongly. Overall, not to an individual, okay? So when a female has intercourse, is she both at risk with her resources and with her health? Absolutely. And it's super duper resource intensive. It's very difficult to do on your own, right? So what tends to happen with mammals, and not just humans, by the way, we are not at all the most monogamous of mammals, is that typically speaking, when women have sex and have a climax, they actually pair bond more likely than males. When males have sex and have a climax, the pair bonding isn't as evolutionarily an important strategy. Does that make sense to you? Because are they as, I'm not even talking about humans, just talking about mammals. Are their resources as at risk and their health as at risk? No, they are absolutely not. Now, I know some of you guys are dad and you're like, hell yeah, it's expensive. But that's because you chose to stay, right? The female doesn't have a choice. It's there, right? So what has been historically a more evolutionarily stable strategy is that if you end up raising that offspring, make sure it's yours. Yeah? So what it does is increases male-male aggressions and increases territoriality and that kind of stuff. And they've experimented with this in the lab. It's so damn interesting when they experiment this in the lab. If you take a group of males and you make them play Monopoly, and everybody gets pissed off when you play Monopoly. It's the worst game ever. But then you actually give them a little extra testosterone and a little extra vasopressin, they will come to blows over Park Place. So they've experimented with these in psych experiments. It's kind of interesting. So again, and then, of course, the male is characterized by ejaculation, which is rhythmic contractions of the smooth muscle throughout all the glands and all the tubes that causes semen to move into the urethra. The distal region of the urethra doesn't have any smooth muscle, but all the way until the last one-third. And then the brain has more vasopressin than oxytocin. And then let's go to the refractory period and the resolution stage. Okay, so refractory period is the recovery time after a climax in which you can't have another one at all, in which climax is physiologically impossible. I'm not talking about psychologically, just physiologically impossible. It doesn't actually exist in women. There is no physiological limitation to back-to-back climaxes. I'm not saying women can always access that. I'm saying there's no physiological limitation to back-to-back climaxes. And in males, the refractory period can be minutes when you're 14 to days when you're 70 something. And what is happening during the refractory period in males is all of the secretions are regenerating, and it takes a little while before you can actually have this occur again. And so there's a physiological limitation. And then the very last stage in both sexes is the resolution stage. And the resolution stage has different chemicals that are released. It's characterized by profound relaxation. My favorite neurotransmitter is released during this stage. It's called GABA. It's your chill neurotransmitter. It's like everything's cool, right? And then genital tissues, heart rate, blood pressure, breathing, muscle tone all return back to normal. In the female, the uterus falls back into its resting position. The vagina relaxes to normal dimensions, and then the male has loss of erection in addition to those other things. Cool? Okay. So did I mention this to you guys last time? I don't know if I did. I thought this was kind of interesting, and you might, did I mention the sex verification thing? Okay, I might very well write a bonus question about that because I think it's interesting. So if I read a bonus question about it and you've actually read it, you'll be able to do a bonus question. If not, you'll have to probably do a different one. Okay, so, and then all of this is just kind of interesting things that you might think, and we're done. We're done. And you guys don't even have to come on Monday, which will be great, right? I still do though. Okay, done.